Okay, I'll be right back. So results in baking are really important, as are recipes for results in cataract and refractive surgery. So we have some really great speakers in this session. First up, when smile becomes a frown, managing complications of smile by Dr. Sheetal Brar out of India. Second, results of a comparison between gauge ultrathin wall and 27 gauge in sutureless intraocular lens flanged technique in diabetic patients. Now, this is a 24-month follow-up study by Dr. Matias Iglicki of Argentina. Third, which IOL is appropriate to use in patients that had previous refractive surgery by Dr. William Trattler out of Florida. And fourth, no wiggle, no cry, cataract surgery in pseudoexfoliation patients by Dr. George Beiko out of Canada. Well, thanks for joining us for this results-oriented session. Let's get right into it.
Hello everyone, I'm Dr. Sheetal Brar, a senior consultant working at Netradham Eye Hospital, Bangalore. I'm very excited to be participating in EXPO, one of its own kind of online meeting, wherein I'm looking forward to a lot of excitement, colors, energy, as well as academics. I'm grateful to my friends at Media Mice, Matt and Ruchi, for inviting me to this wonderful conference. So today I will be talking about smile procedure and how a smile can become a frown and how to manage complications in smile and bring back the lost smile of the patient. I am a consultant to Carl Zeiss Meditech. So essentially, there are two stages of smile procedure. The first stage is laser delivery, and the second stage is the stage of lenticule dissection. So during the stage of laser delivery, you can have problems such as black spots, suction loss, and during the stage of lenticule dissection, you can have issues such as lenticule getting stuck under the cap, lenticule getting torn, and cap tears, as well as inability to find the lenticule itself. Now, coming to the black spots are the areas where the laser does not get delivered. Now, they can happen due to obstruction of the laser beam, due to meibomian secretions in the tear film, any dirt or fibers under the contact glass, any ink which has been used to mark the cornea for cyclotorsion compensation, excessive corneal dryness, as well as excessive use of topical anesthetic drops. Now, the risks associated with black spots could be the surgeon can face a difficult tissue separation, which can lead to a potential damage to the stromal bed as well as a delayed visual recovery. Now, let's see this video of black spots. Now, here I have a very uncooperative patient who is very anxious and is not cooperating for docking. So what happens here is that I'm touching the cornea repeatedly for docking, and due to this, the secretions of the meibomian glands, they get stuck under the contact glass. Now, after this, when I fire the laser, you can see there are a lot of black spots, and consequently, I'm facing a difficulty in dissection of the tissue as well. So when this happens, basically when you have to dock the cornea again and again, it's very important that before firing the laser, you must clean the undersurface of the contact glass using a wet sponge as shown in this video. So, of course, we have spoken about prevention and management, minimum use of topical anesthetic drops, immediate docking after eye preparation, wipe the cornea and contact glass with moist sponge, or you can also break the suction manually if you see there are multiple areas of black spots involving the center or the visual axis. So in such cases, you might not want to proceed with the laser itself, and you can also change the cone. Second very important complication that I want to discuss is suction loss. Suction loss can happen due to sudden movement or squeezing of the eyeball, excessive fluid around the cone, improper cone selection, as well as any loose conjunctiva which is there around the cone, especially in contact lens wearers. These patients have loose conjunctiva, and there is a higher chance of conjunctiva getting sucked inside the cone when the suction is applied. So whenever there is a suction loss, the Visumex automatically goes into a specific mode based on the stage of the procedure. Now, we all understand that there are 4 stages of SMILE procedure: the lenticule cut, the lenticule side cut, flap cut, and the flap side cut, which is the incision. So you can expect suction loss at any of these 4 stages while the eye is under suction. So the dictum here is that whenever you have suction loss, when the lenticule cut has progressed to more than 10%, you will have to convert to femtoLASIK in that situation. Whereas if your lenticule cut progress is less than 10%, then you can proceed with SMILE. Or if you have suction loss at the stages of side cut, cap cut, or cap side cut, you can still proceed to SMILE. Okay, so I'll show some videos that will make it more clear. So this is the first case where suction loss happened when the lenticule cut was less than 10%. So you can see the eye was docked and immediately there was a suction loss. Now, how do you know the stage of the progress of the laser? So on the right screen, you get this kind of a display which shows you the percentage of progress of each stage. So lenticule progress was less than 10%. So you can completely revise the procedure. You can again dock the eye using the same cone as shown in the video, as if nothing has happened, and take out the lenticule. Now, case 2 is when the laser had progressed beyond 10%. Okay, see here. So patient had sudden movement and there was suction loss. In this particular stage, the machine does not allow you to proceed with SMILE. So if you want to complete the procedure, you will have to convert it into a femtoLASIK or do a PRK. So here I'm using a flap mode and I'm putting my flap parameters and creating a flap here. Okay, so you might have to change your parameters because the flap is slightly bigger than the cap, and I'm able to do a LASIK procedure here. Case 3 is suction loss happening at the stage of side cut. Now, this happens very fast because side cut takes very less time to occur. So you can see the lenticule cut was complete, but as soon as the side cut had started, there was a suction loss. And you can see from the right screen, it was around 38%. So it was not complete. So I can redock again and I get another side cut, a new side cut basically, and I'm able to proceed with SMILE again. And the 4th one again is during the cap cut here. So you see the lenticule cut is complete. The side cut also was complete, but before the cap cut could start, there was a suction loss. Now again, I can recenter, use the same cone and proceed with SMILE here. So to avoid suction loss, really important to have a proper head positioning of the patient. The nose should not be touching the cone. Patient should be given clear instructions just to look at the green fixation light, and they should not be talking and should not be very anxious. They should be very relaxed. And you must inform them that the green light will disappear at some point of time and they just have to keep their gaze steady. And it's also good to give them a countdown of time so that they are aware for how long they need to keep the eye in the straight gaze. So the next complication I'm going to talk about is lenticule getting stuck under the cap. Now, this is a really, really common complication that happens in the hands of a beginner who is starting with SMILE procedure. And the main cause of this is entry into the deeper plane first. Many of us don't consider this as a complication if it is realized well in time, because you can always find the top plane and separate the lenticule and take it out. But yes, for a beginner, it can be quite distressing because if they go into the deeper plane and then they think that it is a superficial plane, they would actually want to go deeper to find a deeper plane, and then there is a risk of creating a false plane altogether. And if a false plane is created, then that can cause a lot of irregular astigmatism and a poor visual outcome. So I have a video here that shows this complication and its management. So the surgeon started the case. He found the top plane, and then he also found the bottom plane. the surgeon is again and again entering into the same plane here. So when this happens, most of the times it is the deeper plane which you have dissected first. So if you realize this, you can rectify it immediately on table. You can use the sharp side of your dissector and insinuate the Sinski into the cap and the lenticule and find the top plane. Then dissect the lenticule and take it out, as shown in this video. But if you are not able to find the lenticule or the top plane, it may be better to abandon the case for the day and take it up on another visit after doing the OCT, or you can also refer the patient to a higher center for management. So once recognized, it's better to stop and identify the superficial plane. You can also use some kind of rescue instruments which are in the form of rake or a hook, which can be used to catch the edge of the lenticule in the inferior part where it is stuck, and you can then wriggle the instrument towards the incision that separates the lenticule along its entire circumference. Next complication is the lenticule tear, which is again a common complication, especially in cases where the lenticule itself is very thin. So in low prescriptions, low myopes, especially those under 3 diopters, it's something that can be expected. Other very important cause is having an opaque bubble layer. So if energy levels are not well optimized, you can have thick opaque bubble layer, and this can lead to a lenticule tear and difficulty. And also black spots can also be one of the important causes. So let's see here, lenticule tear. So you see in this particular case, there is a very thick opaque bubble layer in the periphery. Now the surgeon is facing difficulty in removing the lenticule here, and when he's using a forceps to take the lenticule out, because of the thick obial in the periphery, the lenticule was actually not properly separated, and you can see there is a wedge-shaped defect. So it's very important for the beginners and even for the advanced surgeons, if they had any kind of difficulty in dissection, to always check the lenticule, keep the lenticule on the corneal surface and check for the integrity of its edges. It's also important to do a slit lamp examination at the end of the surgery to check for any residual lenticular fragments. So in this particular case, we used slit illumination to guide us to remove these fragments, and the outcome was very satisfactory. So complete separation of lenticule from both the surfaces as well as the side cut along the circumference is very important. And especially in low myopic individuals, you can do a little bit of changes in the settings. You can increase the minimum thickness or the peripheral lenticular thickness to 25 to 30 microns. So minimum in Visumex, what is allowed is 10 microns. You can increase it to about 30 microns also. So this increases the overall thickness and you can remove the lenticule without any problem. Very common complication that is seen in the hands of beginners again is incision or cap tears. Most of the times it happens when your incision is too small. So if it's 2 millimeters, then the surgeon can have difficulty because the movements would be more side-to-side movements and there is a chance that the incision can extend. Or if the technique of dissection itself is improper, the surgeon is using a lot of side-to-side movements and not using the instrument like a fulcrum, that is again one of the causes. So the management, if the tears are small and they are away from the pupillary area, they can be left as it is. If the tears are larger, then it is important to use a BCL and they generally heal with a faint line. And it's also important for the beginners to use a slightly larger incision size of 4 mm or so. So here is a video showing incision tears and its management. So this case also had an OBL. So you can see there's a big incision tear. And this is another case showing the same. But since this tear is away from the pupil, we have actually not used any BCL at the end of the surgery. But you have to be very careful removing the lenticule under the tear because you don't want to extend the tear as well. So this is another case where the cap got caught and there was a big tear where I thought I should put a BCL and I put the BCL on the eye and the outcome was quite satisfactory here. Patient achieved a vision of 6/5 uncorrected and the tear healed with a faint line. So the last complication is inability to find the lenticule. If you're not able to find the lenticule in 10 minutes, better to postpone the case for about 4 to 12 weeks and allow the cornea to heal. Reassess the case using topography, OCT, clinical photography. And if you're able to manage, you can manage to a PRK or LASIK depending upon the situation, or you can also refer the patient for exploration to a more experienced surgeon. So here I have a case which presented to us after 7 days of a complicated smile surgery. On the OCT, you can see that the whole lenticule is there in the pocket. We did a re-surgery, removed the lenticule, and the lenticule, after the lenticule was removed, the post-operative topography looks very smooth. Patient got a very good outcome. So in conclusion, a proper technique of docking, optimized energy levels, and meticulous surgical technique is extremely important for smile surgery. This would minimize your complication rate as well as improve visual outcomes in smile patients and also give you much more confidence. Thank you so much.
Thanks so much, Dr. Brar, for those great ophthalmic thoughts. We always appreciate your insights in ophthalmology and on social media. Next up is Dr. Matias Iglicki, as I mentioned, out of Argentina. Let's go for it, Dr. Iglicki.
On behalf of Katarina Bush, Dina Sur, myself, and Professor Lowenstein, we are truly delighted and grateful for this unique opportunity to share our paper published, resulting comparison between 30G ultrathin wall versus 27 gauge needle when we are going to fix aphakia in these patients. This was done by members of the International Retina Group, and we were surprised about the beauty of the intraocular lens when we use the 30G ultrathin walls. What was more astonishing for us was the stability of this lens with this needle. Again, I want to thank my co-author, Tina Sur, Katarina Bush, and of course, we are using these needles in order to get these results. I want to finish this first presentation by showing my financial disclosures and also by saying that we published this paper in Acta Diabetologica where we shown our results, and this was a before and after this paper. This would not have been possible without the help of Professor Lowenstein. Without her support, we have not published 46 papers in this last year. So Professor Lowenstein, on behalf of the International Retina Group, thank you so much for your support. Let's go straight to the paper. So there are several reasons why to take out the information we have in the eye and select the best technique, in this case, for instance, intravitreal injection, which is the most common intraocular surgery done today. But we are retina specialists and we faced a complication of cataract formation. So let me show you how one patient will be the best candidate in order to get the best results. So everyone wants to get this surgery, which is a cataract surgery. We inject viscoelastic and then we insert, in this case, a multifocal intraocular lens, and the following day the patient is able to read, to see for far and near vision without any glasses, and much better than before because the cataract was taken out. But as we are retina physician, we face with these kind of patients. As you can see, lens drop into the vitreous cavity, or intraocular lenses, as you can see here, because of trauma, drop in the retina. We have to fix it. Or in some cases, so cases of Marfan's disease, where the lens, as you can see, is dislocated and we have to fix the aphakia. So this is the scenario. We have a patient without posterior capsule, without capsular support, and we had to fix that. And we were using the 27 gauge needle, and we saw that the dislocation and decentration was high. So we changed with 30G ultra thin wall. As you can see here, the result. there is the intraocular lens is very well centered, and then the following day you can only see 2 dots when you melt those ones. So if you don't see those dots, if you see just the central picture, you are not going to realize that this patient had a complicated cataract surgery before. The technique was published in ophthalmology by Yamani and collaborators, and the statistical significant difference was that with this technique, with the 30G ultra-thin wall, the stability was much higher, and this patient fared much better. And this is our first option when we see an aphakic patient. So the important thing here is to check if the haptic will go inside the needle. And here is the case with this needle. So we have a wound which is very little and smaller than 27 intrascleral, and then we have the same lumen inside the needle because, as I said, it's a ultra thin wall. And this is what happens if we use a 30 ultra thin wall. The inner diameter is 0.14, where the haptic is 0.15 millimeters, so it won't fit. Of course, ultra thin wall needle has 0.20, and then it fits properly. So we have only the 300 microns outside and 200 microns inside. So that's why the ultra thin wall needle is the best option for this surgery. And this is what we use. And again, it's very important to check and see the needle at the beginning and the haptic go inside the needle, because this is a ultra thin wall and the lumen is bigger than the standard 30G needle. But let's go straight with this surgery. So this patient, as you can see, has a dislocated intraocular lens and also a tension ring with this. So what we do at the beginning is we mark 3 and 9 hours, and then 2 millimeters from the limbus, and then 2 millimeters inferiorly. We take out the, in this case, the lace and the ring as well, and then we bend the needles 40-degree angles. We inserted it, we make the tunnel, and then you can see the needle, the ultra thin wall needle inside the vitreous cavity. We grab the lens, we put the haptic inside the ultra thin wall needle, and it's very easy to put it. And once it's there, there is no way that that haptic will go away. Once it's there, we pull out. As you can see on the screen, the haptic is going out, and as soon as it's going out, we grab it with a forceps. In this case, it's serrated, and then we melt it in order to create a button. And we do the same thing with the second one in order to get the lens stable there. As you can see how beautiful the intraocular lens is. Of course, every single surgery that needs vitreous traction or vitreous interaction, we finalize it with full vitrectomy. As you can see the following day, as you can see, as I said, 2 points, blue points, and the intraocular lens is very well centered. As I said, we were surprised about the beauty of the technique, but what was more astonishing for us that the astigmatism that this technique induces is almost nothing. As you can see below the surgery, they have a preoperative more or less 10 diopters. Then postoperative is almost 0, and then the astigmatism induced by the surgery, if we place it in the same position, is perfect. But not everything is perfect, so we have to take care and do the technique properly. Otherwise, we have some issues on safety profile. So let me tell you some take-home message with you. When you perform this technique, we have to use the perfect lens. Otherwise, we have this. The haptics in the maneuver, we can pull it out and the lens will be dislocated without haptics. So we have to be very gentle and elegant in order not to get this complication, which is the broken haptics. And we will go a little bit further. We can get, because we didn't do a proper vitrectomy, a full retinal detachment due to traction. So every single intraocular lens fixation finishes with a vitrectomy, full vitrectomy. As I said, there are several complications if we don't follow this, and we have seen this on the paper with 27 gauge needle, but not with 31 gauge needle. As you can see, this is what happens if we don't go straight to the haptic and we are not doing it properly. And this is what we have. We have an intraocular lens inside the eye. So the patient had one surgery that was complicated and then the second one. So the 30G ultra-thin wall helps us in order not to have these complications. Again, very important. We are trying to avoid this. This is before and after. This is with 27. That didn't happen in our paper with 30G ultra-thin wall needle. So in conclusion, sutureless intraocular lens flange technique using 30G ultra-thin wall needle is more predictable than 27 gauge. Less complications in affected diabetic patients compared to 27G needle was shown. That is to say, is safer and the intraocular lens is more stable, and in 24-month follow-up with 33 ultra-thin wall. Of course, a randomized controlled trial is mandatory in order to compare diabetic and not diabetic patients in order to extrapolate these results in non-diabetic patients. We did that in diabetic patients where you know that the sclera is very stiff, and that's why we've seen with 27 gauge needle a lot of dislocation. But with this 30G ultra-thin wall needle, the stability at the IOL centration was statistically significant better with this needle compared with 27 needle. So in conclusion, we have not used any more 27 gauge needle for this technique. On the other hand, we do use 30G ultra-thin wall needle in order to perform this surgery. So on behalf of the International Retina Group, I would like to thank you so much for your attention.
The right gauge tool is definitely important in ophthalmology. And next up, we have Dr. William Trattler speaking again on which IOL to use in patients with previous refractive surgery.
Hi, I'm Bill Trattler from Miami, Florida, and I'm excited to be part of the Cake and Pie Expo, and I'll be presenting on the IOL selection in post-refractive surgery eyes. I practice in Miami, Florida at the Center for Excellence in Eye Care, and I'm very honored to be here with you today. I work with a lot of companies, and these are my disclosures. Probably most relevant are those that have IOLs such as AcuFocus, Alcon, Bausch & Lomb, BVI, and RX sites, as well as J&J. So what are some of the keys? We know that we're seeing lots of patients coming in for cataract surgery who have a history of previous LASIK, PRK. Some people with SMILE, of course, RK, but really I want to focus mostly on the LASIK patients. And I think the first key is to get preoperative topography, because that's really going to help us understand if this patient is a good candidate for surgery, or they might expect some issues to develop in and around the outcomes of cataract surgery. So we also want to get an OCT of the macula, because patients may also have some issues of their macula, and we want to identify that and tell the patients ahead of time, because we don't want to find out afterwards. I'm sure you all realize that if we can identify things ahead of time, it works way better than if a patient ends up unhappy with surgery and then we tell them there's a problem. It may have been pre-existing, but the patients would rather know ahead of time. Of course, figuring out the right IOL calculations will be a challenge. There's lots of different formulas that can help us, and I'm sure you're aware that with the refractive surgery ones, such as previous LASIK, you often have to know if it's previous myopic or previous hyperopic LASIK. And of course, we love providing presbyopic IOLs to patients who have a history of LASIK in general. I mean, that's our thought. These patients have wanted to be out of glasses for their whole lives. They've had LASIK. They've been out of glasses. They want to stay out of glasses. But not all patients are candidates for the presbyopic lenses. So we're going to talk about how we identify those patients as well. We are at a very fortunate time because right now we have so many excellent post-refractive, post-LASIK IOL formulas. When I think of the ones I use the most, we have the Barrett True K. That's worked really nicely. It's integrated into many of the biometers. You also have the Hey Gazelle. I'm in the US, so I use the ASCRS website as well if you want other formulas. But for me, the Barrett True K has been what I've been using the most, but the Hey Gazelle is also excellent in my experience. Again, there's many other excellent formulas out there. We know that some other formulas are coming out, and then we have other options as well that we can use adjustable IOLs. So the nice thing about the, for example, the RxSight lens is that you can take it, place it in a patient who has a history of previous LASIK and get close and then fine tune it afterwards during the post-operative period. The new version of the RxSight lens will actually have something called Active Shield, which will block UV light. So you won't necessarily need to have patients wear the UV blocking sunglasses at all times. So that's an exciting new innovation with them. Another option is going to be the small aperture IOL, the IC8. That's looking very promising as well. I understand the results in Australia have been excellent, and we're excited here in the US to have access to that for our patients with a history of previous LASIK. So it should be simple. We have great formulas, new IOLs, but there are a lot of challenges. First, how do we predict patients that are going to have a good postoperative outcome? Because surprisingly enough, sometimes there could be hidden in those topographies some level of irregularity in the corneal shape from previous LASIK. And we really want to identify those ahead of time and tell our patients what to expect. We want to figure out who's a good candidate for presbyopic lenses and figure out how to enhance patients who end up unhappy after cataract surgery because they're a little bit off target. What's the best option if they've had a history of previous myopic LASIK, IOL exchange, piggyback lens, more corneal refractive surgery. So we're going to talk about that as well. But to begin with, let's talk about map interpretation or topography interpretation. So here we can see very nicely that these are patients who've had previous myopic LASIK. You have a nice blue flat center. It's round, it's symmetrical. And then you can see a peripheral ring of red and yellows where it's a little steeper. And so this is the classic appearance of a patient that has well-centered myopic LASIK maps. And so we want to understand what normal looks like when we're seeing our patients. Now, here you can see this patient has central steepening. They tell you they have a history of LASIK. While this could be keratoconus, this is actually hyperopic LASIK. And that's where we make the center of the cornea steeper. So again, you want to be able to identify these two because the formulas want to know whether they have a history of myopic or hyperopic LASIK. Now, what about this patient? This is a 62-year-old male, had LASIK 15 years ago. They want a myopic, they want a multifocal lens. Is this patient a good candidate for a multifocal lens? So let's take a look at this topography. You can see a nice round peripheral rim, which is great. But looking more centrally, we see there's a little bit of irregularity. We see a little area of green, one area of blue. And so again, can this patient have a multifocal lens? But if you look even more carefully, you'll see that there's one side has steeper cornea. There's kind of in the 38 range. The other side is much flatter, 34 and 35. So there's a significant gradient right in the center of the pupil. So this patient's actually going to have a loss of best corrected visual acuity after cataract surgery. They will not achieve typically 20/20 with glasses because there's this significant irregularity in the visual axis. So you really want to see this and talk to patients ahead of time, let them know they have significant irregular astigmatism and help them understand what to expect after cataract surgery. You definitely want to avoid a presbyopic lens here. They will not be happy. Now let's look at some other examples. So we have a patient who has central flattening. Here it looks nice and round. You see the rim of steepening peripherally. So this patient looks good. They definitely are a candidate for various options. What about this patient? They had a history of previous myopic LASIK, and now right in the middle there's this area of red. It's kind of vertical. What is that? So when you see a patient, and again, we're talking about looking at the nice blue central optical zones, but then you see something coming up that's rising or that's red, which means it's steeper in the middle of that, that could be a sign of post-LASIK ectasia. So this patient had previous myopic LASIK and now they're developing keratoconus or ectasia years after their LASIK surgery. Here's another example of post-LASIK ectasia. You see here that this area is kind of rising up. The red is steeper than the blue, and so right in the middle of the axis, visual axis, you can see that there's significant irregular astigmatism. Both these last two patients would benefit from cross-linking to stop this progressive condition from worsening over time. Even though patients can be older, I'm sure you're aware that patients with a history of LASIK who develop ectasia in their 50s, 60s, and 70s can clearly progress. So cross-linking can be helpful there. So what about this patient? This patient came to me, they had lost their best corrective visual acuity, they had cataracts, and they wanted cataract surgery. And I identified that this cornea was a little bit irregular. We can take a look here, that there's some irregularity in the visual axis. And we actually went with a monofocal lens. We talked about it ahead of time. You can see here that there's this, I show the pupillary border, which is in blue. The green area is a flat area, the red area is a steep area. And even though I saw this ahead of time, even though I told the patient, oh, you may not be quite 20/20, but you're going to be pretty close, the patient actually was really unhappy with their quality of vision after surgery and felt that they saw worse after cataract surgery, even though I used a monofocal lens. So just be cautious that these patients, that the cornea can be part of the reason that patients aren't seeing well. And even when you do cataract surgery, even if they have an obvious cataract, if it's not too advanced, they may not feel that their improvement is that much, or in this patient, not at all. So just be aware of that. So about this patient. So this patient had LASIK in 1995, just shortly after FDA approval here in the United States. I was not the surgeon, but I did take care of this patient when they came in to see us after cataract surgery. So you see this patient, we got the maps from before cataract surgery. You can see the optical zones are not quite centered. Let's take a little closer look. And clearly we don't want to use anything but a monofocal lens. So we look more carefully, you can see that there's a big gradient in the pupillary axis in both eyes. So look, this is the right eye. You see there's an area of 20.6 below and 40.5 above. So 20 diopter gradients right in the visual axis. So this patient, not surprisingly, after cataract surgery, which is when I saw the patient, was very unhappy. They need to wear a scleral lens to get really good vision. And they did see well with the scleral lens. And again, even the monofocal lens, they were unhappy, so be aware and talk to patients about that. Their other eye also, they had a gradient, and thankfully this eye was not as bad, but they also ended up wearing a scleral lens in their other eye as well. So just to be aware of these type of patients and to be able to counsel them ahead of time is really critical, so they know, patients know what to expect. So what about patients who have previous laser vision correction, and they want to know if they can have a presbyopic lens versus a monofocal lens. And when I see these patients, they're coming in, I actually realize that there are some patients that have had a history of previous LASIK that actually can do quite well with a monofocal lens because their cornea has been set up so that they have some range of vision. And just to point out again, you can have patients that have previous myopic LASIK, they have a flat cornea, and they have patients that have previous hyperopic LASIK with a steep cornea. And we call the one on the left, the myopic LASIK, positive corneal spherical aberration. That's where it's flat. And we call it negative corneal spherical aberration in the hyperopic LASIK, where it's steep. So negative, just so where it's a steep cornea, positive is a flat cornea. It gets to be flat. And so again, positive spherical aberration here after myopic LASIK, and we have steep after hyperopic LASIK. And how do these shapes impact the range of vision? So the question here is, will we potentially achieve more range of vision with a flatter cornea or a steeper cornea? So what's the one that's going to help us most after cataract surgery to get the most range of vision with a monofocal lens? So one thing to point out is that when you do presby LASIK, which I don't think there's anything FDA approved in the United States, but internationally there's presby LASIK. And what they try to do is they try to steepen the central part of the cornea, and that provides more depth of field. So here's two examples of presby LASIK, patients who've had presby LASIK, where the central part of the cornea has been steepened by the laser so that the cornea is steep in the middle. And if you notice, it's not that dissimilar from hyperopic LASIK. It's not the same. The ablation factors are different, but still the goal is to steepen the center cornea because that gives more range of vision. So with that in mind, when you have, the point is that if you have positive spherical aberration, you're not going to expect to get much range of vision. And actually in those, I often will use a negative aspheric monofocal IOL. For the patients who have a steeper central cornea, like in hyperopic LASIK, they already have a negative spherical aberration. They're going to get a little more range of vision, which is a nice, I guess, nice thing for them to. And I do let patients know that they might get some range of vision. They might be able to see the computer without glasses if I target distance. And for those, I'm going to use, typically I'll use a neutral aspheric lens. There's a number of choices here in the United States. You could also use a positive aspheric lens, but I typically use the neutral. But there are different choices that we can make. And again, when you have a flat cornea with positive spheric aberration, it's nice to use the negative aspheric monofocal lens. And with the steep corneas, I use a neutral aspheric IOL. So I think, again, as we think about our options with laser vision, patients with a history of laser vision correction, I have to understand that we have a lot of ways to make patients see really well with cataract surgery. However, even with all our best efforts, patients could end up under or overcorrected. So what are our options when they end up off target? We can use glasses or contact lenses that they were probably wearing them for a while after the LASIK, but before their cataract surgery. So let them know they may end up, that's an option. We can consider PRK over the LASIK flap, or PRK if patient have a history of previous PRK. That works quite nicely. We actually started writing about that option back in 2001. And so it's worked very, very nicely. It's been my main preferred method of enhancing patients with a history of LASIK is do PRK with mitomycin C over the LASIK flap. Well, then we can also do other things. You can lift the flap depending on the situation. You can also do a piggyback lens or an IOL exchange. So there are a lot of options for patients who end up off target. So I think those are nice options. Now, there are some really cool, new, exciting technologies that we now have available. So one is the adjustable IOL. So it's made by a company called RxSight, and this is a lens that we place the lens at the time of cataract surgery. Patients wear UV blocking glasses, and about 3 to 4 weeks after surgery, we'll do our first, we'll still be measuring their vision, but we'll actually do refractions, and then we can do treatments to adjust the IOL power. The newest version will actually have this UV blocking shield, so the need for UV blocking glasses will be significantly less. The second option will be the small aperture IOL. That's a really exciting technology as well. As I mentioned earlier in my talk, that it's been available in Australia for a little while, and the results have been quite positive. It gives a very nice range of vision in patients. It does help in patients with a history of previous LASIK because it can help give that range of vision and be less sensitive to being slightly off target. We also have the option of presbyopia eye drops. These are getting closer to FDA approval in the United States. These are drops that make your pupil smaller and will give more range of vision. So it might be something that you can use in a patient that's close after cataract surgery. They may have some aberrations. You could use this drop to make the pupil smaller, and that might help improve the quality of vision after cataract surgery in patients with a history of LASIK. So that, I hope this is a good overview on how we plan our procedures in patients with a history of LASIK. We have a lot of advanced IOL formulas. I told you that I love the Barrett TrueK and obviously Hexel I used for a while as well. These are great formulas. It's best if it's integrated into your biometer because there's less chance of a mistake when you're transferring data from one area to another. So it's nice to have it integrated. Of course, the newer adjustable IOLs and small aperture IOLs are quite exciting as well and will help improve our outcomes. Of course, there's still challenges that even with all these great options for our patients, it's still difficult to predict the best corrective visual acuity post-op. Even though I'm quite experienced, I still can not always identify that a patient may not have the best vision because the slight irregularity can actually be quite impactful in certain patients. We still want to try to do our best to determine who's a good candidate for presbyopic IOLs in patients with a history of LASIK. And that's something that we're going to keep working on. Some patients can be very happy, but some can be quite unhappy. And lastly, how we enhance our patients that end up off target is another key. We have a lot of options, and I'm sure we'll continue to have future options. So I hope this is a very helpful overview. These are my kids. And again, it's my pleasure to speak with you today and look forward to seeing you at a live conference soon. Thank you so much.
Dr. Trattler, thanks for all the support and love over the years. We've really appreciated having you as an advisory board member to CAKE. And now next up, we have Dr. George Beiko, who's going to teach us not to wiggle and not to cry cataract surgery in pseudoexfoliation patients.
I'd like to thank the organizers of the Cake and Pie Expo for inviting me to be part of this program. Today I'd like to share with you my thoughts on pseudoexfoliation and in particular the implications of phacodonesis. These are my financial disclosures. None of them are relevant to this talk. As ophthalmologists, we are all very familiar with pseudoexfoliation syndrome. It is a systemic disorder with ocular manifestations. There are deposits of snowflakes on or in various structures of the body and in the eye, in particular the conjunctiva, cornea, iris, anterior lens capsule, zonules, ciliary body, and anterior vitreous face may be affected. Pseudoexfoliation syndrome is associated with systemic disorders including cardiovascular disease, which is 3 times more common in pseudoexfoliation patients. Patients may have strokes, hypertension, myocardial infarctions, Alzheimer's disease, hearing loss, and abdominal aortic aneurysms. But as ophthalmologists, we are in particular interested in cataract, glaucoma, and ocular ischemia being associated with pseudoexfoliations. It is generally reported to be prevalent in up to 10% of the population and up to 20% in some populations. Pseudoexfoliation syndrome increases with age after 50, and it has been reported that there may be a 10% annual increase for pseudoexfoliation in persons over the age of 50. There is no reported sex predominance. So what are the clinical findings? We can make the diagnosis by slit lamp examination with an 85% sensitivity and 100% specificity rate. The diagnosis is made by observing snowflakes at the pupillary margin and on other structures in the eye, as well as pigment liberation after pupillary dilation. If we look specifically at the cornea, there is endothelial cell dysfunction with lower cell density, decrease in cell hexagonality, and an increase in the coefficient of variation. This can lead to increased pachymetry and corneal dysfunction, and it can lead to increased risk of corneal decompensation. In terms of the iris, this is where we see the snowflake material at the pupillary margin with some loss of pigment. The pigment can be deposited on the iris and on the lens surface. We can see iris transillumination defects in a moth-eaten pattern near the pupillary sphincters. And we can occasionally see posterior synechii, as well as decreased function of the dilator and sphincter muscles due to atrophy. Looking at the angle, we can see the snowflake material deposited on the trabeculum. In addition to this, we can see hyperpigmentation due to pigment dispersion, and this is most marked inferiorly. There can also be a scallop band of pigment running along Schwalbe's line or anterior to it, the Sanpaolisi line. On the lens, we can see the material being deposited in 3 zones. There's a central translucent disc with scalloped edges, then there's a clear zone, and then there's a peripheral granular zone, which may have radial striations. And this is the images of various degrees of pseudoexfoliation of the lens. When it comes to the ciliary process and zonules, we again see the snowflake material on these structures. Involvement of the zonules can lead to lens phacodonesis and lens subluxation. The pseudoexfoliation material aggregates at the origin and anchorage of the zonules and invades the zonule lamellae, creating weakness. There's also thought to be a proteolytic enzyme that facilitates the zonular disintegration. Glaucoma is certainly a risk factor for patients with pseudoexfoliation. Having the diagnosis made for 5 years means that you have a 5% risk of glaucoma. At 10 years, the risk is 15%. Men seem to be at higher risk for glaucoma, and the conversion rate increases annually at about 3.2%. At the time of cataract surgery, glaucoma can be present in up to 50% of patients, and we should be cognizant that IOP spikes after dilatation is a risk factor due to the pigment liberation. In the management of the cataract, up to 40% of the patients may have some intraoperative difficulties, and of most concern is the approximate 10% rate of zonular dehiscence. So as ophthalmologists doing cataract surgery, whenever we are faced with this appearance, anxiety tends to grow within us. We are concerned that the presence of this material creates and our minds immediately go to the Titanic. And of concern is that the same may occur during cataract surgery, in which the lens sinks down into the vitreous, being reminiscent of the Titanic sinking in the North Atlantic. In a meta-analysis that was published in 2016, which looked at 3,200 studies and selected 21 for analysis, the odds ratio of a posterior capsular rupture or zonular dialysis was about 10%. Looking at a tertiary care hospital in a prospective study in which over 1,000 eyes were assessed, published in 2019, it was found that 22% had pseudoexfoliation syndrome, 41% had hypermature dense cataracts, and it seems that patients with pseudoexfoliation present with denser cataracts than those without. The mean pupil dilatation was less in the pseudoexfoliation group. 9% had an increased IOP, and 27% had intraoperative difficulties. Most of these were due to poor pupil dilatation, but zonular dehiscence and posterior capsular tear did occur in 8 and 1.3% respectively. So how common is this problem? How common is zonular dehiscence, capsular tear, and nuclear loss? Well, in a retrospective study in which pseudo-X patients were compared with controls, it was found that glaucoma was present in 32% of pseudo-X patients versus 5% of the controls. Pupil dilatation was certainly a greater risk for the pseudoexfoliation patients, but interestingly, there was no significant difference in the surgical complications in the pre- and the post-operative intraocular pressure between the two groups. And most interesting was that pseudoexfoliation did not confer a statistically higher risk for surgical complication in eyes without marked phacodenesis or lens subluxation. When assessing a pseudoexfoliation patient for cataract surgery, it's important to look for the wiggle or phacodenesis. If none is present, then we can be confident that we can proceed with our standard approach with minimal risk of complications. So, in the management of cataract, we should anticipate poor pupillary dilatation, some posterior synechia, higher than average risk of zonular and capsular breaks. Preoperatively, we should be looking for phacodenesis, and we can do this by checking to see if there's asymmetry of the anterior chamber depth and endothelial compromise, and a UBM may be helpful to make this diagnosis. Intraoperatively, we should be looking for folds or wrinkling of the capsule during puncture and capsulorhexis, and minimize zonular loss zonular stress due to nuclear manipulation and cortex removal. For most cases, without phacodenesis or evidence of zonular loss, we can use our standard approach. And this is, for me, such a case. So, having created my main incision, I go in and puncture the anterior capsule. I did not notice any wrinkling, so I went ahead and completed my capsular rhexis, which is larger than normal. I do my hydrodissection. I then take my cannula and I insert it into the nucleus to assess the density. In this case, it's about a +3 density. So I know I can use my akahoshi. I bisect the nucleus, and I don't rotate it because I don't want to stress the zonules. I go in with my phacoemulsification, and I do a slow motion phaco. This is followed by doing my irrigation and aspiration of the cortical material and some polishing of the posterior capsule. And you see the case goes well. I insert my one-piece intraocular lens, and in 90% of cases there are no issues, and you can go ahead and do your standard approach. What happens if you have a small pupil? Well, in that case, you should consider using some means of increasing the pupillary diameter. In this case, I've decided to use a Malyugin ring. This is placed into the eye after lysis of the posterior synechii. And once the ring is in position, you go ahead and do your standard approach, and then at the end of the case, remove the ring. So the ring can certainly be very helpful in cases of poor pupillary dilatation. And if there's any evidence of any zonular weakness or loss, then certainly we should consider using a CTR. So in the middle of this case, we found that there's some zonular loss, and as you can see, there's some fragments left. So I've placed the CTR into the bag. I go in with my phaco tip, and I remove the remaining larger fragments of the nucleus and cortex, followed by irrigation and aspiration of the remaining cortical material, which I do gently and in a tangential pattern so as to not be hindered by the CTR, and the case goes well. So using devices certainly does help in these cases. And finally, let's look at this case in which we have pseudoexfoliation in a patient with corneal astigmatism, small pupil, hard nucleus, and zonular weakness. I start by doing my limbal relaxing incisions to deal with the corneal astigmatism. I then create my wound. As you can see, I avoid the limbal relaxing incision site. I create a Wong pocket anterior to the main incision, and then I create my main incision, which is 2.4 millimeters. My paracentesis or secondary port again avoids the limbal relaxing incisions. I placed phenylephrine into the eye without any success. I'm now using my viscoelastic to dilate, and again the pupil is small, so I will place a Malyugin ring to help expose the nucleus and allow for easier access to the nucleus. Create my capsular rhexis, and then I gently hydrodissect, again trying not to manipulate the nucleus too much. As you can see with my cannula, I'm not able to penetrate into the nucleus at all, so I know that it's quite dense. I decide to use a MyLoop in order to help bisect the nucleus and to prevent manipulation of that nucleus, so that the disassembly of nucleus is done as gently as possible. The MyLoop is placed underneath the capsular rim and then enlarged and passed behind the nucleus, and gently the nucleus is bisected. Once I have the two sections, then I can easily remove them one by one. I do this by going in with my phaco tip, again slow motion phaco, and by bringing the hemisections to the pupillary margin. And I disassemble them gently in the center of the field. It's very important not to rotate those pieces, not to put any stress on the zonules, and to allow the pieces to come to the phaco tip so as to remove them. Once they're removed, I then go in with the IA and gently remove the remaining cortex that's there. And in this case, I noticed that while I was removing that the bag was quite floppy, and I was concerned that the zonules were weak. So I proceeded with placing a CTR in the bag prior to placing the lens into the bag. A 3-piece silicone lens is placed with the haptics in the bag. The Malyugin ring is removed. The viscoelastic is removed. And all seems to go well. Remember to remove the viscoelastic from behind the lens as well. And then final steps are to hydrate the wound, so the paracentesis is hydrated, the Wong pocket is hydrated so as to allow closure of that main wound, and the case is completed without any problems. So in the management of the cataract, a large capsulorhexis during hydrodissection, tap the nucleus to make sure there's no fluid trap. With the small pupil, use some expansion devices, use a capsular tension ring to stabilize the bag if necessary. With phacoemulsification, do a slow motion phaco with minimal manipulation of the fragments. In summary, in eyes with pseudoexfoliation syndrome, without any phacogenesis or wiggle, it should be possible to use your standard approach to obtain a successful outcome. Thank you for your kind attention.